Wonderful. We'll let people start to enter the space, and good afternoon, wherever you are. If it is afternoon, good afternoon. I am in Chicago and it's sunny and beautiful, so signs of spring everywhere, which is making me very happy today. As people start to trickle in, please note that we have sign language interpreters and captioning. Should you need to use those, let us know by adding something to the Q&A if you're having any difficulty getting access to captioning and or ASL. Perfect, and we'll just give it another minute. All right. Good afternoon and welcome to the Docs with Disabilities, Women with Disabilities in Medicine, UME to GME Mentorship Panel. My name is Lisa Meeks and I'm the co-director of the Docs with Disabilities Initiative, and it's truly an honor for our entire team to host this event. Today is particularly significant as we gather during Women's History Month, celebrating the remarkable contributions of women in medicine, especially those that are challenging the norms and rewriting history. Not long ago, merely being a woman in medicine was considered disruptive to the established order. And today, we're not only embracing the presence of women in medicine, but we are also confronting and reshaping the notion of what it means to be a physician within a deeply ableist paradigm. So our panelists today are deeply entwined with the Docs with Disabilities, Disability, and Women with Disabilities in Medicine topic, and they're eager to share their insights and experiences with you. Together, we are committed to fostering disability inclusion and dismantling barriers in medical training. I just really want to quickly extend a heartfelt thanks to our main sponsor, the University of Michigan Center for Disability Health and Wellness, whose unwavering support has made this event and future events possible. And a special thank you goes out to our entire community of partner organizations who have played a pivotal role in helping disseminate this information and get you all here to this webinar. Those include the ACGME, the American Public Health Association Disability Section, the AAMC, the Canadian Association of Physicians with Disabilities, the Association of Medical Professionals with Hearing Loss, the Johns Hopkins University Disability Health Research Center, the Medical Students with Disabilities and Chronic Illness Group, shout out to those folks, the Stanford Medicine Alliance for Disability Inclusion and Equity, the University of California Davis Center for a Diverse Healthcare Workforce, and the University of Michigan Disability Program that's housed within the Department of Family Medicine. So thank you to all of our partner organizations. And now I'm going to hand over the reins to our very capable, lovely co-moderators, Drs. Ortega and Charnsangavej. Thank you so much for joining us.
Thank you so much, Dr. Meeks. It's really wonderful to be here with all of you today, and truly an honor to co-moderate this event with Dr. Charnsangavej, and to really be able to spotlight the voices of a stellar group of physicians and physician learners. So with that, my name is Dr. Pilar Ortega. I am Vice President of Diversity, Equity, and Inclusion at the Accreditation Council for Graduate Medical Education, the ACGME. And I'll let my co-moderator introduce herself.
Thank you. I'm Nalinda Charnsangavej. I am a pediatrician and the residency program director at the University of Texas at Austin Dell Medical School. And we are so looking forward to learning from all of our panelists and learning through their experiences about the UME to GME transition.
And so we would like to actually ask each of our panelists to go ahead and introduce themselves. So we will call out your names and then please go ahead and introduce yourself. So Dr. Megan Creasman.
I am currently a rheumatology fellow at the University of California, San Francisco, and I have an autoimmune disease.
Dr. Molly Fausone.
Everyone, I'm Molly. I just finished my residency in internal medicine at Vanderbilt University, and I stayed for a year to work as the chief resident in quality and safety at the VA in Nashville. I'm an internist, and I'm going to be joining the faculty at UIC next year as both a hospitalist and a PCP. And I have a spinal cord injury, and I'm excited to talk about the transition from medical school to residency.
Dr. Emily Green.
Hi, I'm Dr. Emily Green. I am a fellow in child and adolescent psychiatry at UIC, previously at University of Wisconsin for psychiatry residency. I have a learning disability and ADHD, and I also have children which were birthed during during medical school, sorry.
Dr. Ann Messman.
Hi, everybody. My name is Ann Messman. I'm an emergency medicine physician in Detroit. I work clinically at the Detroit Medical Center. I'm currently the Associate Dean of Graduate Medical Education for the Wayne State University School of Medicine. And I was diagnosed with multiple sclerosis in 1999 when I was in high school and had gone through all of my medical training with this diagnosis. And I also have my mother had MS and was also a physician.
Dr. Jessie Ramsay.
Hey everyone, I'm Jessie. I'm currently a pediatrics resident, third year at Baylor College of Medicine in San Antonio at the Children's Hospital of San Antonio. And I just matched into my pediatric emergency medicine fellowship at Texas Children's in Houston, also associated with Baylor. So I'm super excited for that and excited to help you all with your transitions as well.
And Dr.
Sorry,
Zoie
and I
Sheets.
have dyslexia and ADHD. Sorry about that.
And Dr. Zoie Sheets.
Yes, hi everyone. My name is Zoe. I am an internal medicine and pediatrics intern physician actually at the University of Chicago. And I've been living with a disability since I was about 9 years old. I have a chronic illness that also impacts my mobility. And I'm also excited to talk about the transition because it honestly still feels ongoing for me. And I feel like I've learned a lot in the last year or so about how my disability has impacted both the transition and what it means to be a doctor.
Thanks again, everyone, for joining us, and really pleased to get the opportunity to learn from such a impressive group of women physicians. So let's start with a question for all of our panelists. In particular, we would love to know about how your disability impacted your specialty choice. And perhaps did others give you advice or counsel you to select a different specialty? Can we start with Megan?
So I got sick before medical school, and for me, I never really wanted to be a doctor. I wanted to be a rheumatologist. And that was motivating and clarifying. And it was fortunate that the lifestyle of a rheumatologist does have some balance and a lot of outpatient time. But in order to get there, I needed to do internal medicine residency, which has a lot of potential barriers to someone with chronic illness. And so I did have different people weighing in on, whether this was something that was going to be healthy for me, and fortunately had a lot of encouraging voices mixed into that helped me kind of get to the specialty that really spoke to me and was why I came into medicine in the first place.
I can jump in too. I think that for me, I knew entering medical school that there would be some things that my body just couldn't sustainably do. And I was really comfortable with knowing that I had some limitations. Like, for example, standing in an OR for a long time wouldn't be the healthiest choice for me. It luckily also wasn't what I felt called to do. But I knew that even with some limitations, that I was coming in with a really big strength, and that was having a disability and being a patient. And I wanted to find something that would let me fill some of the gaps that I had personally noticed in my own care. I had had a lot of trouble finding a primary care doctor and transitioning to adult medicine, and finding someone who understood disability outside of pathophysiology. And I also knew that I personally wanted to care for people with disabilities. I think it's really important to name that not every disabled doctor has to care explicitly for people with disabilities, but I knew that I felt called to that because it was a community that had really built me up time and time again. And so I was looking for a space where I felt like I could push back on some of the ideas that caused those barriers for me, and would be flexible enough for my body, and then just personally would align with some of the things I wanted to do. I knew I loved people of all ages and things like that. And so MedPeds just really felt like the right space where I could impact that primary care access and sort of fill those gaps around training and understanding of culture and identity, but also be in any setting, working with any age, and getting a chance to connect with all sorts of specialists and doctors in other spaces, so I could share kind of what I personally found so beautiful about being disabled.
Okay, I can take it from here. So I, similar to Megan, kind of when I thought about medicine, always imagined pediatrics. So I knew pediatrics was kind of my calling, my area where I wanted to pursue medicine. And even before I got into medicine, I had a lot of people kind of say, maybe you should rethink this. There's a lot of reading. There's a lot of need for concentration and focus and being organized in medicine. And then when I was getting ready to apply for residency, or even just throughout med school, I was advised not to do things that were super competitive, such as surgical fields or even emergency medicine. And ironically, that's what I'm doing, is pediatric emergency medicine. But I really noticed that the people kind of making those recommendations were people who did not have disabilities themselves, or at least none that were similar to what I had. And so their experiences were different, and they were kind of making those recommendations based off of assumptions about what I could or couldn't do, rather than allowing me to find out through trying myself. And one of the biggest things I was told was, don't go into emergency medicine because you have to write notes really quickly, or you have to look things up really quickly. Well, it turns out the notes are a lot shorter, and I'm actually really good at all of that, and I learn best in that kind of environment. But I kind of shied away from it in med school. So, and it was during COVID as well. So I never actually got to try emergency medicine in med school. And then my first exposure to in-person emergency medicine was actually in residency. And so my advice is not to let other people tell you can't do something or you shouldn't do something based on your functioning, because you have that awareness of your own limitations and abilities, and you shouldn't allow shoes to can't or can do something. So try it, and if you feel like it's a good fit, that's what you should.
That's great, Jessie. You're a hard act to follow. So like I said, I was diagnosed in high school, and my family, the way I was raised, we were extremely private about medical problems, and therefore I did not disclose anything to anyone at any point during my training, including med school or residency. So nobody was giving me particular advice about which specialty I should go into, and I was able to hide my disability at that time. So nobody really knew what was going on. I did have sort of, because my mother was a physician, she was an OBGYN, and she was diagnosed with MS when she was a resident and was in a wheelchair my entire life. So I kind of got to look at her experience and draw some conclusions from that. So she, before she lost her ability to walk, she developed a tremor in her right hand. And so the first skill of hers that she had to give up was operating. And I was worried that if I followed in her same path, that if I developed a tremor, I couldn't do anything in the operating room. I ultimately chose emergency medicine, which is procedure heavy, or can be, but not quite to the extent that working, as a surgeon or in an operating room is. So I took surgery off the table. It was absolutely not my calling. So that was not a difficult thing to cross off of the list. But I would say that I don't know if it was just being naive or in denial, or just not being mature enough to think it through. Once I took surgery off the list, I looked at all of my other options equally and didn't really rule anything in or out based on my disability, because I just wanted to live my life and pursue the field that called me, which was emergency medicine. And I've found it to be an incredible field for somebody with a disability. So I've had nothing but good experiences. And since I have disclosed, I've had incredible support amongst my faculty and chair. So I have nothing but good things to say about emergency medicine.
I can follow Anne. So I think my disability didn't have a huge impact on my choice of specialty. I have a spinal cord injury, a power wheelchair, and I'm in internal medicine. But I think learners both with and without disabilities gravitate towards fields that are a good fit for their skill set. And I think internal medicine was a really good fit for my skill set and my interests. It's heavy on interpersonal interactions, heavy on data. There's a lot of like cognitive heavy lifting, and those were things that really appealed to me. So I think I was counseled away a little bit from neurology. So there's people that had concerns about the physical exam. I think those concerns were misguided, but I also didn't really have that as high an interest in internal medicine for me. So it didn't end up making a big impact on my decision. And then I think a lot of people expected me to pursue PM&R just because of the interaction with people with disabilities and the interaction with athletes. And those are both interests of mine. But it just wasn't the thing I was most interested in. And so for me, I think the sort of fit for my skills and my interests won out over everything else, and internal medicine has been a really great fit. So it's been a home within medicine that I'm really happy with.
My decision to do psychiatry was probably very different from the rest of the panelists. So I was diagnosed with a learning disability when I was in first grade, but did not actually get any medication for it until until sixth grade. I had a lot of issues with people calling me stupid, lazy, distracting, things like that really, really messed with my head for a very long time. And even though things got a lot better with medication, with therapy, I did not think that I was good enough to be a doctor. I really wanted to be a doctor. I actually wanted to be a psychiatrist because of my own psychiatrist, who's also an African-American woman. It was a very big deal to see her, to see that these things can happen. But I was so afraid that I would fail that I decided not to be a doctor. And I was actually a master's level licensed professional counselor for about 5 years before I went to med school. And I went down that path because I did not think that I was smart enough to go to med school. And when I was a case manager, managing a bunch of patients with other people, and I was on task, I got all my stuff done. I made sure that everything was done on time or earlier. It was like, oh, I actually might be able to do this. And that's when I made the decision to do that. And actually, I had a lot of pushback from my own parents. My father is a physician, was very afraid of how I would do. I was already married. I already had a child. Everyone was just like, this is going to be too much for you. It was very much my decision, and my husband's probably, that it was just like, no, we're going to do this. And so when I did go down that path, I think that people started to get behind me, but it was very difficult because it was just like a lot of times I heard, just do the PsyD, just get a PhD. You don't have to go to med school. But that's what I wanted to do. And so I think that you should never go off of what other people are saying. I think it's to take it to heart and to know if people, I'm sure that people really do have a positive mind when they're giving advice. But just like others have said, people who do not have disabilities weighing in on that, it can be very difficult for them to understand where we're coming from, what we're dealing with, and even the things that I was dealing with from childhood that I still have to deal with, where it's just like, sometimes you just need someone who will help you to say, like, let me see what I can do. And I found that I can do this. So yeah, I would definitely encourage whatever is your interest to go for it.
Thank you for sharing all of these stories about your specialty choice decision. And Dr. Green, your comments really lead to our second question for all of the panelists, which is how and when, if at all, did you decide to disclose your disability in the residency application process? And if Dr. Fausone could start us off.
Yeah, I'm happy to start. I was pretty intentional about how I disclosed my disability. Like I said, I was applying to internal medicine. I use a power wheelchair. I have a cervical level spinal cord injury, so I have limited hand function as well. And the first thing that I did in preparation to disclose was I went and read the ABIM website, and I figured out like what are the procedural requirements, what's going to be asked of me, and how will I explain to everyone that I'm going to meet these requirements. After that, I went and met with the program director of the internal medicine residency at my own institution, where I was doing medical school, and I met with the chief residents as well to talk to them about if I were to stay at my own institution, what accommodations would I need and what would that look like. And then after that, I did some thinking about like how I wanted to approach the disclosure process in the written application. This was back in the time of in-person interviews, so everyone was going to see me and meet me, and I wasn't necessarily going to have to like formally disclose in person because everyone will see that I have a disability and use a wheelchair. But I wanted to think about how I was going to disclose in the written application. So my general approach was that I wanted people to know from the written application, like my CV and personal statement, that I have a spinal cord injury, that I use a wheelchair, but I didn't want them to know specifics about like what my level of injury was or my hand function. And basically I thought like I will tell them a lot about my level of functioning and they can correctly or incorrectly infer my disability, but I don't want to give them a ton of specifics about my disability and have them incorrectly infer my level of functioning. I thought that sort of level of detail was better left for an in-person conversation. So I told people in my personal statement, I have a spinal cord injury, I use a power wheelchair, I travel, I play adaptive sports, I'm active, I live independently, I've been a patient, all those types of things, but I didn't give them a lot more detail than that. And then I went and had a conversation in person with everyone who was going to basically write anything in my application. So I talked to all three of my letter writers and I asked, are you going to mention my disability in your letter? Two of them said no, it didn't have any bearing on like my interaction with you on the wards. I'm not planning to mention it. And one said yes. And so we had a conversation about what that was going to look like. That was a person who has a PhD in anthropology and had a really sort of thoughtful and sophisticated way of thinking about disability as a sort of cultural phenomenon. And he had, I think, I had no concerns about how he was going to speak about disability. And he really was hoping to mention it in a positive light about how it affected my interaction with patients. And so we just talked sort of in broad strokes about that. And then I talked to the people who were going to write my chair's letter and my dean's letter as well. And asked, like, are you planning to mention my disability? How are you planning to mention it? And we talked about that. And again, just sort of those conversations were a little bit more specific. Like they actually showed me what they were going to write. But we kept it sort of big picture. Their comments basically said, Molly has a disability. She completed all the requirements without interruption. We waived no requirements for her. She did a good job. So not disclosing a ton of detail, but making sure that people knew ahead of time that I was an applicant with a disability and that I had the support of my institution. I talked to a lot of people with disabilities who had made this transition before I sent in my application. And I tried to learn from their experiences. And I think it's exciting that things like the Docs with Disabilities podcast will hopefully prevent people from having to do their own snowball research in the future. But I found that helpful. And I thought significantly about adding like a paragraph to my personal statement or something that had more details, but ended up being worried that that could be like misread or overread in ways that weren't going to be helpful, which is part of how I settled on this approach of like giving people big picture information, but leaving a lot of the details for an in-person discussion.
Emily, would you be able to address the question next?
Yes. So I think next, Emily, if you want to jump in.
Yeah. I disclosed from the beginning. Again, like I'm an older medical student. I actually started medical school when I was 30 on my birthday. And so I went in with a sense of, I'm coming in with a disability. What do you guys have to offer? that's actually how we started our first disability group at UIC, is because people didn't know how to support us when we were like, oh, we need help. It was myself and a couple of friends my year where it's like, we need help applying for accommodations for step one. And literally our counselor said, I don't know how to do that for you. And it was like, I don't know either, though. This is my first time in med school. Like, could somebody help me? And so we disclosed very early. I feel as though for me, and that's not for everyone, it's much easier if I put that on the table, because you're in an academic setting, and some things might be expected. And definitely there was some positive judgments, there were some negative judgments, but I think that it was important for me to feel comfortable in maybe using, recording devices, having to take exams in a different place where it's like my friends don't have to ask, why weren't you there? Because they already know I test separately. So it wasn't a big deal for me, but it was something that I had done my entire school, and so it wasn't new either. But then for residency, I actually, in my personal statement was about me at the pediatrician getting the diagnosis of ADHD for my own child, and how that impacted me, because that was a lot. Feeling like a failure, feeling like I was doing this to my own kid, and then realizing that I was actually like the best person to have him. So it's different for psych, obviously. We're very much person focused, and there's a lot of empathy. And so even so, people did say, like, are you sure you want to turn this in? Like, it's great. You wrote it amazing. It's beautiful. Wanted to cry, but do you actually want to reveal this? And I said yes, because it's a huge part of why I'm a doctor, is because I don't want kids to go through what I had to go through. I want people to be screened early. I want people to get medication. I want people to get support. And so that's what drives me. And so it was just kind of like, I can't really hide this, or put this, because that's what keeps me motivated to keep going. So for me, disclosure was not like, it was not a discussion. It was just like, this is what I'm going to do because this is why I'm here. So mine might be a little bit different, but I definitely disclosed very early. And then for residency, I also, since they had read my personal statement and other things like that, I did disclose very early and asked them, what can we do to get the ball rolling so that I don't get accommodations late, because that was always an issue. And they were very understanding. They gave me certain accommodations I didn't even ask for, which was wonderful. And I think I would say for that, the other thing is just like, do you want to be in a residency where people wouldn't want you if you're disabled, where it's like, oh, I don't know if I want to reveal this. It's like, if this is going to impact, your ability to do things, or it's going to come up, do you want to be in an institution where people wouldn't want you because of that? So that was a conversation that people in my circle, we had a lot of those conversations as well.
Okay, I can go. So I had a lot of similar experiences to Emily, except for that I went to a brand new medical school. I was in the first class, and there weren't any other people in my class who had any disabilities that were disclosed. So I was the only one who was open about it. And my personal policy, similarly, because I have learning disorders and it's an academic setting, I disclose often, because for me, it's important, one, to destigmatize having a disability, really just being disabled in the like societal sense is actually really just being differently abled. Like, we have a different skill set that we get to the same outcome, or even different outcomes, but that are synergistic. And so for me, it was important to frame my disability in a positive light and not leave room for them to, like, gaps for them to fill in in a negative way, because people tend to think about things and insert like the worst possibility, and I did not want that. So I wanted to be able to say, I think that Molly had said this too, I wanted to give them my functionality, like what I can do, and then also state kind of, here are my limitations where I need some additional help or a different way of doing it. And so for me, you know, like testing is a big area where I need extra time in a separate space. And so I had to disclose that early to get accommodations in med school. But for clinical rotations, I hadn't really done that before. And so I didn't really know what to ask for. And that can be a problem for a lot of people, especially if you're diagnosed later in life. And I was in college when I got diagnosed. And so I didn't really know what accommodations were available. And so I think it's important, if you feel like you're struggling and you don't know what the problem is, or you don't know how to fix it, ask around, and having previously disclosed makes that a lot easier to start that conversation than if you are coming in cold, like, hey, I have a disability, how do I accommodate this, like, after the fact. So having that kind of framework set for me made it a lot easier to be like, hey, I'm having problems getting my notes done. How do I make this more efficient? And then, you know, things that I used were like Dragon, which is a voice to text software, like dictation, which really helped. And then I had residents who were like, here's some templates you can use that you can steal from me, that you can just click through so you don't have to write everything out, and things like that, which I didn't know were available. And then my school, I had asked for a text-to-speech software as well, which was super helpful. But then making that jump to residency, where it was only clinical and I was managing patients, like I'm responsible for them, it was a little bit of a different transition. But for me, what I noticed is it was important to disclose to people that I was working with, or who were evaluating me early on in the learning setting, because there are some situations where it could affect patient care. So if it's a patient who could potentially be unstable and they're like, hey, go look this up really fast, I might not be able to look it up that fast. But a lot of people would say, well, you're missing the learning opportunity then. And so I found that if I disclose early on, like the first person or the first time I meet that person, say, hey, I have ADHD and dyslexia. I just wanted to let you know, like, in case we run into any situations that might affect patient care, I tend to request that you just tell me the answer in the moment. We treat the patient, and then I will go look it up and read on it after, or find information on it after. And then I would like to have that discussion we probably would have had ahead of time, but just after. And then they actually really, a lot of people were like, wow, that was really mature and wise of you, because that's something that most people who don't have disabilities don't think about. But they probably would have judged. I've had people say they probably would have judged me for being like, I can't look that up right now, and saying that I wasn't an active learner or something like that, and saying that I kind of helped reframe how they think about other learners who have maybe said the same thing but didn't disclose anything. And so I think for me, it's important in those situations, because I don't want to affect patient care in a negative way, but I also don't want to affect my grades or my evaluations or my learning in a negative way either.
Thanks for sharing all of that, Jessie. I find that very similar to the other panelists. I also chose to disclose really early and often. I didn't have accommodations until partway through college, but I found I kind of developed my preference for how to disclose as I went from one step to the other. And for my residency application, you know, my application was filled with disability related activities, both in terms of like student groups and advocacy, but also research and away rotations. And so I felt like it was only natural that that question would probably come up, the question of how I became interested in this work. And the genuine answer is that the more I got to know my community, I heard concerns that I felt drawn to do something about. And so I wanted to have control over the perception of my disability. And I thought that the personal statement was a really powerful tool to frame disability on my own terms and show right away that it was a strength. And so I did this in my personal statement by sharing one of my favorite patient stories, actually where a patient needed a brand new mobility aid. And because I was using my cane, we got to have some really honest and hard, but also humorous and encouraging conversations about what this was going to mean. And I wanted to show that I was proud of that and that it was something I could offer the program and offer the patients that were a part of that hospital. And I generally found that the responses were really positive. Several programs actually said specifically that they wanted me to help them think through how to be more disability inclusive, which I should note is not necessarily the job of a disabled resident, but my research interests do lie in the transition. So I felt really excited by that. And it showed a commitment that I really appreciated. And the few times I got negative comments, honestly, I was really grateful for those too. While they were more rare, they definitely showed me that this was not a program I felt like I would be welcomed at or would have to work really hard to prove myself. And I would much rather know that up front than to learn the hard way and wind up being somewhere that's hurtful. And so now that that process is kind of over and I'm in my first year of residency, the question is really, how do I do this in clinical rotations? And I found it actually harder for me than it was in medical school, partially because the responsibility is greater. And as was just said, like now I'm responsible for patients in a different way. And so I found myself with a bit more anxiety about it than I'd had before. And so I decided, and this may not work for everyone, but I decided to basically make like a one-liner about myself that I just keep in my back pocket and share with folks. It's a couple sentences that share that I have a disability, how it impacts me, and what my accommodation needs are from my colleagues. So letting them know I use a stool on rounds. I can't take the stairs when we switch from the 5th to the 6th floor in rounds. Just stuff like that that kind of helps them know how to structure the day. And I like that because it again makes me feel like I have control and I feel prepared, but I also have come to know what the follow-up questions will be. So I feel ready to answer those too. And yeah, I think a lot of it is really just about disclosing in a way that makes me feel in control and like I get to decide what my disability kind of means to me.
I really resonate with a lot of what's been said. First, about disclosure as a way to be your authentic self, and also how to control the information and narrative. And I, like Molly, found that the personal statement was a really important way to create my own boundaries in terms of what I was going to share, and not inviting a doctor-patient relationship with the people who were going to be interacting with me and interviewing me. But being really clear that, like, yes, I am a patient and I am a provider with a disability, and those are things that inform each other, but they're not an invitation for you to pathologize me. I also found really a lot of like trial and error in terms of how to, and go from being in medical school to being a resident. And I liked like giving people a lot of different opportunities to interact with me about their questions about how to be part of my team. I would send emails ahead of time to kind of like warn people if I, about my needs, and invite the conversation outside of the clinical environment, and create that space so that there weren't as many competing needs. I think that people are often just uncomfortable, and that leads to a lot of like unnecessary discrimination. And so I love the idea of like your own one-liner. I kind of just had like an email template and then my own like personal template where I would, pull aside the people who I was, after I'd email them and say, hey, like, you can tell I'm using a mobility device today. I just want to make sure that you don't have any questions. And so it was, a lot of trial and error, but the more you do it, the easier it is, I think.
So I worry that I'm going to be the least helpful of all these talented panelists because I did not disclose during residency. So I started training in 2008. That's when my residency started. And I know that's not that long ago, but things have changed a lot since then. And at no point ever in my medical school training or during residency did anyone say anything about we welcome disabled people. Here's how you would get accommodations if you think you want them. There was literally zero about that. So I was like terrified. I didn't, and I didn't really need accommodations per se, like on a day-to-day basis, but I did really, really ridiculous things in retrospect. Like if I had a flare and I had to go get IV steroids, I would do them as an outpatient, which was fine. That's not the ridiculous part. But the ridiculous part is they would keep my IV in and they'd put it like a little wrap around it. And even if it was 90 degrees out in the middle of August, I would go to my shifts. I didn't take any shifts off. I would have my infusion sometimes and go straight to work and just wear like a long sleeve hoodie so that I could cover up my IV access site. And like, that is just so insane. Like I should have just taken, the infusions were 3 to 5 days. Like, why didn't I, think to ask for those days off? But, we just didn't talk about those sorts of things then. And I had great experiences in med school and residency. I was not at places that were malignant, but I just didn't feel safe or comfortable. But the good part of having lived through that experience is that now that I'm in a position of authority, I can change the way that we talk about disability at Wayne State and in my residency programs that I oversee. So it was a great learning opportunity for me.
Thank you all for sharing your experiences in the disclosure process. And there are many questions that we will try to address later on. Our next question is going to start with Anne, but knowing what you know now, what would you tell residency applicants are signs that a specialty, a program, or an institution will be a positive and inclusive learning environment for them?
Yeah, it's a great question. I've been sort of looking at the Q&A in the chat, and I think there's a lot of questions about this, like how do you know ahead of time? So the Docs with Disabilities website has been extremely helpful for me as the Dean of Graduate Medical Education. They have documents that I've essentially been able to copy and paste and put into our communication. So something that we've changed as an institution that I think applicants should be looking out for is when you go to a residency's website or the sponsoring institution's website, do they have very clearly labeled and easy to access information about, we welcome people with disabilities. This is how you would request accommodations. This is the office you would talk to. Please let us know if you have any questions. And we've also added to all of the applicants when they apply to a residency program and they get invited for an interview, they get an email, and in the email, every program director has a statement somewhere in that email that says, we welcome people with disabilities. So, please feel free to apply. And then when the match happens, which happened for us about 2 weeks ago, they do get communication from the program directors, again, telling them we welcome people with disabilities. If you need to or want to request an accommodation, this is the process. So we just put it out there, and we are not scared of using the word disability. I think a lot of institutions might be a little nervous, maybe they don't know the right thing to say, but we've sort of like embraced it full on. And I give a ton of credit to Dr. Meeks because of the collaborations I've been able to have with her, and also the Docs with Disabilities website because of all the information that they've provided publicly that I can just copy and paste into my own school.
I would absolutely second that. I think beyond just having sort of a diversity statement that lists disability, although that's important too, like seeing the tangible details on how you navigate the complexity of having a disability is really helpful. I found during the interview trail, there were 2 specific questions that I would actually ask the residents more so than the program directors. The first of which was, can you share some ways your program has supported you as an individual, your identities, your interests, things like that? And the second was how the program handles the unexpected. So sick call, leaves of absence, parental leave, and things like that. And when residents would have confident, concrete, specific examples, I felt way more certain that their program had sort of a foundation of inclusion and support. But for some programs, I felt that residents would hesitate to answer, have really generic answers that just made me feel like maybe they are, but I don't feel as confident in knowing that. And the reasons I asked these questions rather than specifically about a disability was a few reasons. I think that some programs don't have disabled residents, or they do, and those people haven't disclosed. So there isn't necessarily knowledge. And also not every resident has disclosed to their colleagues yet. So I didn't necessarily want to ask about disability, and they didn't feel comfortable answering because they just didn't want to share that in front of everyone. So I just wanted to see how their culture as a whole may shape their accommodations and willingness to kind of figure these things out. And then the other thing that was really important to me was seeing how how programs responded to my patient story that I shared in my personal statement. A lot of programs, almost every program I interviewed with, brought it up during the interview. And some just discussed it as if it was nothing, just what was in the personal statement and therefore worthy of discussion. And that was sort of, a beige flag, like not super great, not super bad, nothing offensive. Two programs, though, made really blatant comments about their concern that if I use a cane and sometimes a wheelchair, whether or not I could fulfill the duties of a residency, especially things like CPR. And that was clearly a red flag, but also some expressed very genuine excitement about what my disability could mean and how those stories could be, could continue being built. And that was a huge green flag for me. So that was how I kind of sussed out how program directors and leadership may feel. But overall, I would say the biggest thing is trust your gut and also take notes on the gut checks, because by the end of the interview trail, you will have so many interactions that will make you feel so many different ways, and it will be so challenging to remember all of them. So take notes on what folks say when you ask these questions and generally how you feel. Take notes and tell yourself if you encountered someone with a disability on your interview day, so that you can look back and kind of say, yeah, I actually do feel like I'm going to be really well supported here, as all of who I am, being disabled, being a woman, being queer, being whatever it may be.
Yeah, my experience was really very similar to Zoe's. So I also, when I applied to different programs, I initially tried to figure out if they had other residents in the past who had disabilities. And if they did, I tried to talk to those people. Most of the programs I applied to had not had residents in the past with disabilities, at least that they were aware of. And so I approached it in a similar way about trying to think about other people who might have had complicated lives or needs in the midst of residency and how the programs dealt with that. And so I think you can ask these questions to program directors. Most of them are going to give you the answers that you want to hear. And so I would ask residents as well. If the program directors don't give you the answers you want to hear, then you shouldn't be going to those programs. But I think even for people who give positive answers about like how they accommodate people who have things like unexpected time off need, I would ask residents follow-up questions on that. And so I tried to ask about like, how does the program accommodate new mothers? How does the program accommodate people who have a sick parent or a kid at home or a need for themselves to take an unexpected leave of absence for a medical issue? And trying to figure out like for people who have complicated needs outside the hospital or life happens somehow during residency, how does the program deal with that? And I think disability is like one way that people can have some sort of complexity in their life outside the hospital, but there's a lot of other ways. And there's people who don't have disabilities but have other needs outside the hospital might need similar things from the program. So I found those to be helpful conversations. The other thing that I did, my program director at Vanderbilt had said in the interview process to I think a lot of people, but he had specifically said to me, here's my cell phone number. If you have questions, call me. And so I called him on his cell phone before I made my rank list. And I said, look, like I'm thinking about putting Vanderbilt at the top of my rank list. I want to have a conversation about like the procedures that I can and probably cannot do and some of the ACLS things. And I want to know that that's not going to be a problem. And so I had like a very frank and direct conversation with him before I finalized my rank list, just so I could be super confident that I was going to get everything that I needed from the program. In retrospect, I think it would have been fine if I didn't do that, but it certainly made me feel better at the time.
I really agree with, I liked using parenthood as kind of like a shortcut to like, what do you do when schedules change or bodies change or needs change? And I went to Cornell for residency, and I just remember the program director kind of like talking to the room and like celebrating the number of like kids that had been born during her residency and like being really proud of that. And then I also remember specifically the like program manager bringing up health insurance and saying like, I know that this is a really important part of your job and your life, and I want to make sure that you all have like that information. And for me, like health insurance is huge, and I had very few other programs acknowledge that that was going to be a part of a decision. And so those were kind of these like extra clues, because you know, I agree. I think that it can be uncomfortable to like try to like poke around and like find the like underground network of like disabled or like chronically ill people who are already there. And there are different ways of understanding how individualized and flexible and like devoted to residents your program is.
Emily, are you able to speak to this?
Sorry, I didn't know it was just me. I mean, I don't know what else to add to it, because I think that everyone already said it, but I was actually actively pregnant, during, interviews, and it was during a time when I did not show, and then there was a time when I was definitely like, you knew I was with child. And so it's also the reaction that people had, is that something that kind of like threw people off, where it's like, oh, you're about to have a yay, but it's kind of like, they seemed uncomfortable. Was a good way to see, because it's just kind of like what they've said with disability. I mean, it's something where things come up unexpectedly with kids, and so it was nice to hear for the program that I did go to. A lot of people had given birth during residency. When I did ask the residents specifically, because like they said, you don't want to just talk to the program director, but talking to the residents, where it's like they've been very helpful, they're really supportive, and actually they changed the um, parental policy before I got there. So even though I'd already given birth, I was able to take time off, which was amazing. And so it is a good kind of thing to look into, where you're not talking about disability, but as someone who did give birth during that process, that it can that is also a very big concern for a lot of people, where it's just like, do I want to disclose that I have children? Because are people going to see that as me not being able to do things? Are you going to be able to be on call, or what if this and this happens? And so I do know that some people did not want to disclose if they were also pregnant, because of that. And all I would say to that is that, just like, if you do have a child and then you go to a program that's not actually friendly to that, like, you're going to have an awful time, because you already know that these people are like, we don't like people that are, you should take your birth control and be quiet. Like, you don't want to be there, because that's not going to be great for you. So it's just like, if that is what you want to do, if you want to have a kid during residency, you want to go to a place that's, okay with that, and doesn't kind of like look at you crazy with that. And it does help. I think that it was helpful that my program was very family friendly with the disabilities as well. I felt like they really did work with me. They did have someone who was physically disabled, who was already a resident, that also made me feel better about the process. And again, I was there in person. This was before the pandemic. But then along with that, because I knew that they were family friendly, I feel like they also were just more open to, oh, we haven't had a learner like you before. What do you need? And so talking about noise canceling headphones, like Jessica said, like, I use the dictation software every single day. I even use it on Google sometimes, because I do better. I literally, my IQ is higher for verbal than for reading, for obvious reasons. And so I think that when I talk to people about what do I need, it's like, oh, okay, you really are asking for an accommodation. You're not actually asking for us to change the actual oh my gosh, why am I blanking on the word? They're not trying to change what we need in order to like graduate. Like I'm not asking for things to be like hugely like moved. I just need it to be accommodated. And I think that sometimes people get really nervous that you're going to ask for the world. And so also sometimes if you talk about accommodations that you got in med school, it's like, oh, okay, that's what you need. I can totally do that, just because I don't think that they're, you know, necessarily mean people, but literally ignorant of disabilities and what's necessary. And I think that as long as they're open to listening to you and seeing what you need, that's a really good sign that this is going to be someone who can work with you and that you guys can figure something out.
Yeah, I totally agree with everything everybody said. I had very similar experiences, and I think it's extremely important to use that kind of like gut check or vibe check that everybody's kind of mentioned. And I had going from med school to residency, one of the most positive experiences I had was actually in the interview email. They sent out, after I had gotten an interview, they sent an email to me asking, because I had disclosed in my application as well, they asked what accommodations I needed just for interview day. And that was like, wow, I've never been asked that before. And it almost took me back, aback, because I was like, I don't even know what to ask for. But it was really thoughtful, and I was like, this is a group of people who's going to try to support me in whatever way they can. And I was like, that's extremely important, even if they've never had anybody with disabilities. And it kind of turned out, I've been in newish programs my whole medical educational career, and I think that there's something to be said for that, where they are newer and more flexible, and they're not so set in their ways. I don't know if that makes a difference for other people who went to pretty well established programs, but and then the other kind of interview questions that I got, because kind of similar to everybody else, people would bring it up. Some people were a little nervous to ask because they didn't want to offend me, and I was like, no, go for it, I'm super open. I also brought it up first because it's in my application, so ask whatever. But I was really interested in how they asked, or what they asked, their question. And one of the best things, or like best ways for me to differentiate, is I had some people during the interview who kind of framed it like, so, you know, you have these disabilities, how do we know that, or how can you tell me that you're going to be able to pass your boards, or something like that, where it was kind of like a negative question. And I was like, done, red flag. But then I had other people who interviewed me, and they either started out the conversation with, wow, you went through a lot, it's incredible that you've made it this far and overcome as much as you have, and that obviously is a positive recognition of what we go through and what we've done, even if they weren't aware of what exactly that entailed. And then asking questions like, what can we do to best support you and get you to where you need to be, or to make you successful, or to reach your goals, or however they phrased it. But it was, what can we do? And it wasn't even like, that was more of a positive way to say it than what do you need, to me, because what do you need is like, okay, let me make a list. But how can we support you could be anything. It could be accommodations, it could be talking, it could be forming a disability initiative, which a lot of the programs didn't have, or anything. And my med school didn't even have a learning specialist, or like anybody like that. So after I went through, they now have one. So things like that are ways you can kind of get a sense of how they are framing this conversation in their head, and how they'll frame you being there. And supporting you. And I think it's really important that that support is what you're getting, not just the accommodations.
Wow. Well, thank you so much to all of our panelists for these amazing, for being so vulnerable about sharing your experiences. I can tell just from the volume of questions that we're getting in the chat. I'm so appreciative, and our listeners are so appreciative of everything that you're all sharing, and you're really generating a lot of ideas and questions. So we're going to transition now to that question and answer segment of our program, where we're going to actually draw from questions that we're receiving from people who are here with us. And I want to start with a question that is probably on a lot of people's minds, and it is about the experience of other individuals who are with you in the program when you are a learner with disability who requests accommodations. The question is whether you have ever gotten the sense or felt resentment from other resident colleagues, or perhaps from faculty members, or even residency leadership when you have requested accommodations. And anybody on the panel may answer, and not everybody has to answer. So in order to make room for enough questions, we can have one or two people perhaps answer each of these questions.
I can answer this one. I have found very pleasantly that I have not felt resentment from resident colleagues, and I know that that might not be true for everyone. But what I have found is that residency is really hard, and we all recognize that. And so there has been a culture on both sides of my program, actually, of showing up for each other when things are hard. And for me, that often means when I can't physically do something. For others, it may mean that something's going on in their personal life and they need to leave a little bit early. Everyone has needs that will pop up. And so while mine are often related to my disability, there are other ways that I can offer support to people in return as well. And so I've found that often my disability related accommodations have become part of the ethos of kind of supporting each other through residency. Again, not every program has that culture, but I have been really lucky to find at least a group on both the IM and the PED side that I feel that way with. Alternatively, though, I have had faculty, both in medical school in particular and somewhat in residency, who have had very different responses, particularly to my need to take the elevator, no matter how many different floors we're rounding on. I've had a couple folks tell me that it's unprofessional to be seated when presenting, and have asked me to, you can sit during other people's presentations, but you should stand during your own, kind of comments like that. That, I'll be honest, to me, sometimes feel hateful, but sometimes feel like they're just rooted in a lack of understanding of the fact that I can legitimately have a chronic illness and be a resident at the same time. And what I've found has helped me through that is knowing that I likely will not be the person that educates away the ableism that is in that person. But what I do need is people who will counter that. And I just sent this to someone in the Q&A as well, but surrounding yourself with people who know the truth that your disability is a strength and makes you uniquely qualified for a lot of moments, and will say that to you on no uncertain terms, is perhaps the best way to counter the negative comments, so that they feel a little bit louder and it feels like the encouragement just has a little bit more time at the mic.
Thank you, Dr. Sheets. Does anybody else have anything they'd like to share on this one?
I can share.
One. Oh, sorry. Go ahead, Jessie.
You go first, Megan.
I think I'll just briefly say that I think overwhelmingly, I disclosing to my co-residents has been a really supportive and like a way that then they became closer to me, and then I learned about things that happened in their lives, or when they were having a hard time with mental health issue or whatever, that I became somebody that they felt safe disclosing to. I have had one or two really painful moments when I've had co-residents, like there's one rotation where I did extra day shifts instead of doing nights because of medications I was on at the time. And I had a co-resident I didn't know well confront me about it. And I kind of like, my initial reaction was to just like tell her my entire diagnosis and my history and like why this was important. And then afterwards I felt kind of like I was like put in this corner that I felt uncomfortable with, and I had to like debrief with my friends about it. But at the end of the day, like kind of like Zoe was saying, like it's not my job to make other people more open-minded. It's my job to like take care of my patients and to like learn how to be the best doctor that I can be. But it threw me for a loop and like took me some time to like not keep replaying that encounter. So like I think it happens. And it's like a learning opportunity because the next time it happened, it like threw me for less of a loop.
Yeah, I've had similar experiences, mostly supportive, but you know, there's always ignorant comments, just because people who don't live with disabilities aren't really aware of other people's needs necessarily, or it's less common that they are. I would say initially, I don't think I've really ever had negative comments about receiving accommodations, but I was scared about it because I was receiving extra testing time, and a lot of people run out of time on tests, and I didn't want that to be a source of like retaliation or anything like that. And really it wasn't. And I think that hindsight, you know, I shouldn't have been scared about it because, you know, yes, I'm getting extra time, but I'm also spending more of my time taking a test, and you're out having a party afterwards, you know, and things like that. Or, you know, I still read super slow, so proportionally we're the same. And so I didn't, I knew that was the case, but I didn't necessarily let myself think that until residency. I was just kind of like, I don't care anymore. Like, and I've really found that my co-residents are actually part of my accommodations. They are so supportive, and it can be anything from like, it's been a long day and we're at the end of the day and I can't read this long HPI that's like 20 paragraphs, and I'll have one of my co-residents who will see me just go, ugh, and then they'll pop over and be like, oh, here, I'll read it to you. And so they're super supportive. They know that I struggle with that, and then they are there to help me get through it. Or if they know that someone is going to need a particularly long note, they will offer to take that admission, and I'll trade with them, or I'll take 2 short ones. And so being open about kind of my needs, or like where I struggle most, has allowed them to help me, but it also allows me to like give back, and show that I appreciate them. And so it's kind of, and someone else talked about like being there for other things, not just disabilities. It like people really do feel like they can trust you because you've been vulnerable with them. And I've had a lot of people disclose a lot of things with me, and they feel like safe telling me those things because they know that I trust them as well. So I think it can be a very positive and powerful impact on your experience and your safety net in residency and beyond. So you know, if you feel safe in telling people, then that I don't think you should hesitate.
Thanks for sharing, and also for talking a bit more about some of these perhaps unprofessional interactions as well, but also glad to hear that we have positive support systems. Another question from the group, which is a little bit more specific, is about how do you handle inappropriate questions or comments, particularly in interviews? Does anyone have any advice for our listeners?
I feel like I've been in this spot. Sorry, Jessica, we're like on top of each other. Here, you go first.
Okay, all right. We're on the same wavelength for sure. So I'll go. I know I just talked, but I think the biggest thing for me was to kind of, like I said before, just reframe it in a way that is positive. So whether or not they are intentionally or unintentionally being offensive or ignorant, I would say, you know, there are people who either, you know, need these accommodations, who are very functional and can do these things that maybe you're not aware of. I'm one of them. Here's how I do it. And I make it very like a matter of fact and not defensive or aggressive, because those things can always come back to bite you, and someone will take it personally and put it, like file a professionalism report or whatever. And I've had that where I did address it with somebody and they did report me for professionalism for not taking feedback well. However, because I have disclosed to literally everyone and anyone and their children, my program director already knew that was not the case. So when I got called in to talk about it, he was like, hey, just so you know, this happened. And I was like, that's not surprising given the interaction. And he was like, what happened? And so I just told my side of the story, and then they waived it. That's one thing that I think is beneficial about disclosing early and often is people get to know you and they know what you're working with, and they you have that kind of like background support as well. I have also learned from other things where I'm not sure if anybody knows, but I had a lawsuit for getting accommodations for the steps. And in that process, I learned very quickly, don't put anything in an email or don't say anything that you would never want published for anyone to see. And that is a very good like life motto to live by, because you can say things or do things that you regret later. So always when you're addressing those negative things that people do it in a position of, hey, you may not be aware, let me just make you aware, but this is what's going on and I can do this. And that kind of maybe will help reframe it without being taken in a really negative way.
Just really quickly, I really agree. And I think the two strategies I've used, one is to say, like, the way I would frame it, or like the way I would ask that question, or like, I'm like, I think what you're asking is, and then answer the question I want to ask, I want to answer, and kind of it, even if I am internally like not the place where I want to be giving people the benefit of the doubt, because I'm feeling a little bit attacked, it implicitly gives them the benefit of the doubt. And then I think the second thing is being really positive about really good things that have happened and the ways that other people have like modeled how to have the interaction, and bringing up like, my medical school really, believed that disability was an element of diversity. And that really was empowering and helped, me in like X ways, and like connected, with like this group of people, and, whatever it is, to just demonstrate that there's a different way of thinking about it without telling the person you're talking to that they're thinking about it in a limited way.
Thank you. Those are really thought-provoking examples from your own lives. And it reminds me about what we call microaggressions or macroaggressions that often are coming up for people, including individuals with disabilities, because of their disability. And oftentimes we're also referring to these as subtle or not so subtle acts of exclusion. So this kind of leads me to our next question, which is around actually requesting accommodations. There are a lot of questions in the chat about this topic, and around, how do you specifically ask for a certain accommodation? What if you have issues with sleep deprivation, for example? What do you do with a call? So the question, I want to broaden it a little bit beyond that specific example, and think about how, in what ways have the provision of accommodations for you been a critical aspect of you being successful in your training? And on the flip side, because some of you, like Dr. Messman, you've had leadership experience as well in residency programs. I'm curious as to your perspective around how do you kind of disseminate information to faculty around what accommodations are reasonable and permit someone to successfully train. Because I'm seeing a lot of questions and concerns around people being labeled as unprofessional, for example, or maybe not able to successfully complete a training if they need that accommodation. So if we can kind of talk about how you've been successful in either advocating for your own accommodations, or how you've helped others who are in leadership positions kind of have those, what they need to know around what accommodations they should be providing.
I can answer briefly for the from the leadership perspective. I think generally speaking, especially when you're talking about a program director or an APD, they're not there, generally speaking, to alienate their residents, make their residents feel badly. I think they're usually there because they love residents and they love GME and they want to be a good leader. What I've found as well is that a lot of times when it comes to accommodations, disability, they don't know the words to use, or they don't even know, like, how does a resident get accommodations? A lot of them still think, or used to think, that the resident has to go to the program director and explain the whole story and then ask for accommodations. So from my perspective as a leader, the nice thing about being the associate dean is that there are certain meetings that all program directors must attend, and they have to listen to me whether they want to or not. We had one of those meetings actually 2 nights ago, but the nice, I have a captive audience at that time, so I can talk to them and just say, just in case you guys aren't aware, this is how accommodations work. The resident or the incoming resident does not have to disclose anything to you. They may choose to, and I hope that you create a residency environment where someone feels comfortable disclosing, and we're working actively towards that. But I explained to the program directors, they go, for us, it's OEO, which is the Office of Equal Opportunity. OEO determines with the resident, what the accommodations are, et cetera. And then it goes back to the PD. But I think a lot of it is just lack of knowledge from the standpoint of the program leadership and faculty, and just having the ability to educate them has been, I think, really helpful to sort of demystify what accommodations and disability looks like for learners.
I think one thing that's been helpful for me is sort of taking the approach of, before asking for the accommodation, centering on what the barrier is. And I want to start by just saying, like, ideally, the world is just accessible, right? Like, accommodations take a lot of work and effort on the part of the disabled person. And it's often because there is an unnecessary barrier that should just be eliminated for all people. And so it can be exhausting to navigate this for all of us. And I've found that to kind of make it go a little bit smoother, things tend to go better when I talk about the barrier before I talk about what I need fixed. And so I'll say to someone, like, my chronic pain tends to be exacerbated if I stand for a long period of time. The solution that I've found that works for that is using a stool during rounds. Or my body will become too fatigued if I am awake for 28 hours or 24 hours. I actually can do like 20 hours as long as I have a break in the middle. Could a fellow cover my pager? Like, kind of offering the solution after the barrier. Which feels so simple, but I think sometimes people truly don't understand the way the medical system works against bodies that don't fit what has been deemed the norm. And so providing them with this is what's going on for me before making the request tends to invoke a little bit of empathy that I didn't always find when I didn't share that part of what was happening as well. And then reminding folks, as obvious as it feels to all of us, reminding them that these truly are to level the playing field, rather than to kind of give you an unfair advantage. Again, feels so obvious to everyone who's needed an accommodation, but truly doesn't always feel obvious to other folks. So starting with kind of, I really want to make sure that I'm performing at the same level of my co-residents, and here are the kind of the things that are getting in the way of that, was helpful for me after I sort of got denied accommodations and have now navigated my way to having them.
Yeah, I think that language is really helpful. And just a short, like, in addition to that, as like offering not just that allowing you to perform at the level of your colleagues, but allowing you to show your competency and not your disability. And so these accommodations are there to allow you to get to the same outcome or the outcome that you need to show in a different path, not cutting out the path. Like, you're not taking away the work or the learning or anything like that. You're allowing this person, me or whoever it is, to do it in a way that is meaningful for them and useful for them, not doing it in a way that someone else has done it and or that is expected just based on society or anything like that. And so I think that wording should include allowing me to show my competency and not my disability is important as well.
Great. Well, thank you. And as we are close to wrapping up, we have one last question that we'd like to pose to the group before we turn it back over to Lisa for concluding remarks. What do you wish you knew before you entered the process transitioning from UME to GME? I think similarly, are there advice for the people who are going to be making that transition?
I could start. I would say that, like, you're not going to know everything beforehand. And I really wish I could say, like, oh, if you have ADHD, like, do this, this, and this. And if you have, do this, and it's like, I can't. It depends on the institution that you're at. It depends on what level you're at with your disability, whether you need a wheelchair, whether you need a stool, it's everyone is different. And so just giving yourself that grace, that this is a learning process and that you go into that asking for what you already know, but also being open to things change, and knowing that I may have to say, hey, I know that I asked for this, but I've realized that actually I need this instead, or I need this in addition, and not feeling like you have to apologize for it, because it is a learning curve for anyone and everyone, because we're all individuals. So just being nice to yourself and being honest with others, just saying, this is what I know I need, but things may change, and being okay with that.
I think I would just say, I wish I knew how rapidly the landscape was changing on this. I applied to medical school in 2015, and I think the range of responses I got was like maybe actively hostile to mildly concerned. And I applied to residency in 2020 or 2019, I guess, going to 2020. And I thought the range of responses I got was like mildly concerned to moderately enthusiastic. And I think that's continuing to change. And so I think people should feel confident talking about their disability as an asset, as a component of diversity, equity, and inclusion, as something that sort of informs how they perform patient care. And then I think the responses on the residency side, especially in 2024, are going to be very different than they were 10 years ago. And that should probably inform how applicants are thinking about disclosure and about the discussion of disability in their applications. And that's something that I've seen in my short time in medicine, and I didn't have a full grasp of when I was putting together my application for residency, but is, I think, increasingly clear to me year to year as I'm in this space.
I would also add that I wish, as a first-gen student, that I had known just how much medical culture puts forth this idea of being superhuman, and how much messaging can kind of make us feel like disability simply cannot be compatible with that. But also the knowledge that literally every single person in medicine has limitations. I think that's actually what the Docs with Disabilities podcast has been really helpful in helping me frame, is people talking about both the strengths and the things they struggled with in a completely normal way, because it is normal. And every single doctor with and without a disability is going to have things that they struggle with or don't click for them or whatever it may be. But that was so not normalized for me when I first started medical school. And I actually failed my first 2 block exams of medical school because it just wasn't working for my body. And I had that messaging saying that meant I couldn't do it and wasn't good enough until I plugged myself into this world that is sort of a different culture and approaches things a little bit differently. So I wish I'd known that having limitations is actually expected and normal, and that all I need to do is identify them so that I can ask for what I need to, pass the retakes.
Yeah, building off of that, I agree with all of that. One thing I just wish I knew / wish I could tell anybody and everybody is don't be afraid to ask for accommodations. And in fact, if you're thinking of asking, or even if you don't know what to ask for, ask anyway. And it could be as simple as, I'm struggling with this. Do you have any suggestions on how to go about accommodating that, or any suggestions on methods to compensate for that? Because you're going to run into situations where you may not know. There may not be something that you've encountered, or somebody who's had a similar disability to you, and you don't know what to ask for, but you know that you need help, but that you can do it with the accommodation. And never shy away from asking, and don't apologize, because they are obligated to get you there. And if it's something that they can't do, ask what the best way, or offer, or say like, okay, if you can't do this, can we do this instead? Or if you can't do that, how would you go about doing it differently? What else can we do? And so never assume that they know that just because you have a certain disability that they should just offer you all of these different things, because they probably don't know either. And so that's the other thing that I think my friends have made that mistake, is they say, well, they should know. They don't. And so, and if they do, they'll probably ask, hey, do you want this? And so if they're not asking you that, they probably don't know. So ask for what you need, because otherwise you won't get it, and you shouldn't put more struggle on yourself trying to work through it or trudge through without the accommodations than med school already is, or residency already is, because medicine is hard, and don't kill yourself over it.
Thank you so much, Jessie. And thank you to all of the panelists and to our co-moderators, Dr. Charnsangavej, Dr. Ortega. I mean, just so grateful for all of your time. And we're going to go back to getting you some information. This is only sharing part of my screen, so I'm going to try to get it all in there. And a few announcements as we end our time together. Just wanted to let you know that there are some new mentoring programs. And so we're talking about mentoring today. And I think this is just a very needed space. I'm going to try to navigate this. I don't think I'm doing a beautiful job, but we'll get there. And so I'm so excited. One of my favorite groups ever, medical students with disabilities and chronic illness, has launched a one-on-one mentorship program. And Sarah Turner is going to be putting some links in the chat right now, but we'll also link these to not only the YouTube video of today's webinar, but also to the podcast episode that will feature today's webinar. So they are doing a mentorship program. There are 2 links, one for mentors and one for mentees, and we encourage you to check out that program. There's also, of course, the well-vetted, established DMP program through SMATI, and we love all of that group and what they're doing for health professions and for community support in this mutual mentorship program. So please check them out as well. And Sarah will be putting some links in the chat. And then finally, of course, our own mentorship program, which is specific to women in medicine. So women with disabilities in medicine. And we will be opening our applications in May. We had our pilot year this year. We had space for 12 mentees. We had almost 100 applicants. And we're very quickly scaling up our support. So we're excited to bring this program back with Diana Seahas and Allison Kessler at the helm. And then we are so proud to announce that we received the Macy Catalyst Grant Award, and we are looking for partners. There's some links in there with a video done by myself and my co-director, Justin Bullock. And we talk about what the hub is going to be. We have this wonderful partnership with the ACGME. We encourage you to let us know if you're interested. We'll be finalizing the selections next week and are anxious to get started on creating all of these resources for GME. And then finally, last but not least, is our wonderful partners at the AAMC who have put together this amazing Ideas Learning series that is focused specifically on disability representation and inclusion in academic medicine. And the link will be there, which will take you to all 4 webinars. We encourage you to watch all 4 if you can. I love that they're including a student webinar where you're learning from the learners, but also my very favorite people in medical education, the disability resource professionals, have their own panel. And I really encourage you to sign up and see what these amazing people, these warriors of access, as I call them, are doing for medical education. And then finally, we're so glad that you were able to join us today. Please be sure to link to us on, I'm not going to call it X, I'll keep calling it Twitter, and also to check out the podcast. You heard several people talking about the podcast and what a difference that podcast had made in their lives. And so many of these lovely individuals, some that I've known for over a decade, have mostly all been interviewed. They're very near and dear to my heart. Thank you, thank you, thank you for me. And I know our audience has just been blown away. My phone has been blowing up with people watching today and just saying, this is the most amazing thing. I've learned so much. So thank you all so much for your time, for your vulnerability, as Pilar said, and for sharing with us some of the ways that you navigated that UME to GME transition. And thanks to our audience for joining us. Please, if you know someone who would learn from this, share the YouTube video or share the podcast episode that comes out. And be sure to catch the podcast episodes that include many, I think all of our lovely panelists have been on the podcast in one way or another. And have a lovely weekend. Thank you all for joining us.